Hello everyone. Today we are going to see about supraglottic airway devices. So this is an important class because every year at least one question, I'm pretty sure one picture question will come from this, and MCQ will also come from this because this is a very important topic regarding entrance examination. So I'm going to divide this topic into two. So in the first topic we will see about the introduction, the importance and uses of the airway, supraglottic airway devices. And in the second topic we will see the individual airway LMA devices. So supraglottic airway devices are also called as laryngeal mask airway or LMA, laryngeal mask airway. So you might wonder why they are named supraglottic airways. So I will give you a simple example. We all know that from the airway anatomy classes that the entrance to the larynx is called as glottis. So when we put a device above the glottis, it is called a supraglottic airway devices. So supraglottic airway devices, it consists of face mask, airway, oral and nasopharyngeal airway, and LMA. But in general, supraglottic airway devices in common clinical practice, we refer it to as LMA. So in endotracheal intubation, we go inside the larynx through the glottis into the trachea and we secure the tube in the trachea. In LMA, we put the LMA, we keep the LMA around the glottis. So that is why it is called as laryngeal mask airway. And this is very important instrument in the current clinical practice because it can be easily inserted by a non-medical or non-trained person in the field itself. So when a patient arrest in the public place or when out of hospital scenario, as a minimally trained person or emergency medical staff can itself insert the LMA. They don't need to intubate the patient. Intubation is difficult. But they can easily insert this LMA and they can give respiration to the patient. And in emergency arrest situation inside hospitals itself, before arrival of the trained person, the staff nurse itself can insert it. And the third thing is, in difficult airway scenarios, in scenario where we are not able to intubate the patient, it becomes a very difficult airway, nobody could intubate it, then during that time also this LMA can be used as a rescue device. So I will show you how it will be inserted. We will see in the next slide. So this is Dr. Archie Brain. So he is the brain behind this LMA. He was the person who invented the laryngeal mask airway, and he took the idea from that of a Goldman's dental nose. So this doctor in 1988. So it is a very recent device. Almost only some 30 years ago only this device was invented by Dr. Archie Brain. He is a British anesthesiologist, and it came to practice by 1988. That is why that year. Actually, he invented the LMA much before, but we don't need to remember that. So this was the first ever LMA he created. So what he created was he took a dental nose piece and he attached it to a cut and off an endotracheal tube. So that is how he was able to ventilate. And this is kept in the museum in London. So they might keep this photo and ask you whether to identify this thing. Now we will see a video regarding LMA insertion. So in this video, they will show you the technique. This is an actual patient getting intubated. So before that, I want to tell you something. In anesthesia practice, LMA is also used for one more thing. In patients who are needing a small duration surgery, a minimal duration surgery, or a daycare surgery, in these patients, LMA is much better because if you need to intubate, you need to paralyze the patient. You need to keep the patient on ventilator for during the surgery. But in LMA, you can just sedate the patient, insert the LMA, and then you can leave the patient to breathe for themselves. You can keep the patient on spontaneous. So that is why in daycare surgeries, LMA is more preferred than that of endotracheal intubation. Now we'll see the video.
Once the patient has been suitably prepared to receive the laryngeal mask, the patient is ventilated.
So you can see the patient has been brought into the theater and she's been pre-oxygenated with 100% oxygen.
It is best held at the proximal end, just below the 15mm connector. The slightly larger diameter tube allows greater control when introducing the cuff portion into the patient's mouth. Under direct vision, hold the tube between fingers and thumb.
So now they have pre-oxygenated, induced the patient, made her sedated. Now they are going to insert the LMA. So this is the position. So the patient's head has to be extended, the neck has to be flexed, like in an intubating position only. And we have to open the jaws, we have to push down the jaw, and we have to hold the LMA like a pen. So this is a classic LMA. So you have to hold the LMA like a pen, like this, and you have to insert it. You have to hold the LMA like this, and you have to insert it. Okay.
The mask into the oropharynx with a slight twisting motion to negotiate the tongue and tonsils.
Now, once
the tube tip
LMA
of
is
the partially inflated cuff
what we have to do
is positioned
we have to
behind the
cuff
incisor teeth,
so that it surrounds the larynx.
Insert the tube at an angle towards that of the
inflated.
ear. A slight lateral rotation of the tube between 30 and 45 degrees allows the mask to slide over the tongue and prevent the tongue from...
You can even tilt the LMA slightly to avoid the tongue coming in way of the LMA.
Entering the atrium of the mask. The angle of insertion is maintained as the tube approaches the posterior wall of the pharynx. At this point, the tube naturally rotates to lay flat against the base of the...
So now the LMA is in the places in front of the larynx, and it's rest on the posterior pharyngeal wall. Now you have to inflate the cuff.
Tongue and presenting the blue line in the midline position.
It completely surrounds the laryngeal inlet. And the tip of the LMA is occluding the esophagus. The proximal end of the LMA is covering the larynx, and it is very close to the base of the tongue.
At this point, the tube is continued to be pushed in the same direction, as it is generally maneuvered into the hypopharynx. Resistance will be felt as the tip of the mask rests on the upper margins of the esophagus.
Once again, they are showing the same thing.
When the tube is inserted fully into the hypopharyngeal region and the tip of the cuff rests on the upper esophageal margins, this causes air to be displaced within the cuff and assists in creating a seal.
Okay. So now that we know how to insert an LMA and how LMA sits in front of the larynx, we will see the further details about now positioning. So the mask rests on the floor of the pharynx. We know that the posterior surface of this LMA. So the posterior surface of this LMA rests on the floor of the hypopharynx, and the sides. These sides will sit on the pyriform fossa, and the upper border of the cuff, that is this border of the upper border of this cuff, is behind the base of the tongue, and the tip of the epiglottis may rest within the bowl of the mask or under the proximal cuff. The epiglottis may be here or it could be outside. That is what they are saying, and this tip will go into the esophagus. So whatever we discussed in the previous slide itself, the tip is in the esophagus, the proximal end is in the base of the tongue, and it's covering the larynx. Now advantages. So this remember this is a very important MCQ question. This is what I want to tell you in this presentation. So advantages of the supraglottic airway devices over endotracheal tube. What is the advantage? So avoidance of laryngoscopy. See, laryngoscopy, we use this instrument. You might have seen laryngoscopy during your internship, during your UG days. So laryngoscopy is a painful process. You need to paralyze the patient, you need to sedate the patient for laryngoscopy. For this also we sedate the patient, but the response to laryngoscopy is much more than that of a simple insertion of LMA. So LMA you just insert it like this. It's just like some straw which is inserted, but laryngoscopy is very painful. So you need to paralyze the patient. So that is avoidance of laryngoscopy, and less bronchospasm. See, in endotracheal intubation, you are putting the tube into the bronchi, into the trachea. So that may cause laryngospasm or bronchospasm. In this, we can avoid the incidence of laryngospasm and bronchospasm is much less compared to that of endotracheal intubation, and greater tolerance at lighter planes. See, in daycare surgeries, in small duration surgeries, you need to maintain the patient you don't need to sedate or paralyze the patient too much, because they need to go home at the end of the day. So lighter planes of anesthesia itself is enough. Patient will tolerate the LMA very well than that of an endotracheal intubation. Less cough during emergence. See, before extubation, you might have seen patients coughing and bucking and struggling with the endotracheal tube. But with LMA, it will be very minimal. The patient will be very comfortable. Sometimes even the patient will respond to you. Sometimes they will open their eyes and you will ask them to give some do something. They will respond. It will be very very quiet and comfortable for the patient. Now again, continue the advantages of supraglottic airway devices. So it avoids tube within a tube situation, leading to minimal resistance in the patient's upper airway. See, in endotracheal tube, you are putting a tube inside the trachea, which is also a tube. So that will cause more resistance for the patients to breathe. But here, nothing like that. Normally, airway resistance will be there because you are not entering the glottis. And lower hemodynamic stability. So normally intubation will cause hypertension and tachycardia, sometimes even bradycardia and arrest. So those response can be avoided. And endobronchial intubation could be avoided, totally avoided, because in normally endotracheal tube intubation, if you push the tube too much, like some interns or some doctors who are first time intubating, with the enthusiasm, what they will do is they will push the tube so much inside, the tube will grow into the one side bronchus. Right side bronchus into the endotracheal tube will enter. That is dangerous because one lung will get all the air, all the gases. The other lung will not get anything, and this the right side lung will get hyperinflated and it could cause barotrauma. But in airway, you are not, in LMA, you are not entering into the bronchi. I'm sorry, you are not entering into the larynx. So there is no problem of endobronchial intubation. One MCQ point. Endobronchial intubation in adults happen on the right side because right side bronchi is more in line with the trachea. In pediatrics, it is not so. Both sides are equally bifurcating. So both sides endobronchial intubation can occur. In pediatric adult, it is right side. In pediatric, it is both sides. Now coming on to ease of insertion and smooth awakening. So anyone can insert. You saw the procedure, it is very simple. And some of the devices permit endotracheal intubation through the laryngeal mask. So we will see that in the next presentation. Some LMAs can be used for intubation also. Now indications. So instead of a face mask and pharyngeal airway, so normally face mask ventilation, we know we have to hold the face mask with one hand and we have to squeeze the bag with the other hand. In the video itself, first you saw, no, he held the face mask and he was pressing the bag. So both his hands are occupied. So that can be avoided. Anesthetist hands are free. So whenever hands are free, we can do many things. We can write case sheet. We can do other things like putting a center line, blocks, or we can do multiple things. So our hands will be free and more reliable airway. Like upper face mask ventilation and is not so reliable because whatever gas you are giving will not go into the patient's lungs. Some may escape into the atmosphere, some may go into the stomach, but here it is much more reliable. So instead of tracheal tube, difficult intubation can be avoided in emergency situation by a non-anesthetic staff, whatever I told you, as an aid to extubation. Some people, they before difficult intubation, difficult extubation, they use LMA, and for difficult intubation. So we know some LMAs can be used for intubation also. So in emergency as well as both in emergency and non-emergency pathways, that is it can be used for intubation and rescue measure. Like during arrest, when you are not able to intubate, you can use this LMA for rescue measure. Contraindications. So we need to go through the mouth. So if there is a tumor in the mouth or small mouth opening, we cannot do it. Any oropharyngeal or pharyngeal or hypophrangeal mass, esophageal pathology like caustic injection, and any patient who requires a definitive airway, that is a patient with a full stomach, patient obese patient, and whose fasting status is not confirmed, and pregnancy patient. Pregnancy is considered as full stomach. That is why we are going to intubate the pregnant patient and not put an LMA. And multiple injuries, acute abdominal injury, thoracic injury, conditions with delayed gastric emptying, history of GE or D, all these conditions LMA is contraindicated. Simple thumb rule is any condition with which needs a definitive airway, any condition which needs a definitive airway, you have to avoid LMA. And supraglottic airway device has limited value in patients with poor lung compliances. So lung compliance is bad when the patient has pneumonia, or when the patient has a restrictive lung disease. In those patients, you cannot ventilate within LMA, because LMA, there is a ceiling pressure, there is something called as ceiling pressure, there is something called as leak pressure. We will see in the next slide, you will understand. Now complications. Very minimal complications seen almost in all patients with sore throat. See, you are putting a tube into your throat, and obviously post-operatively patient will complain of throat pain. And major complication is aspiration, that occurs 2 per 10,000 cases, but that is very dangerous. That is why you should avoid LMA in conditions with full stomach. See, in these patients, when the LMA is not properly fitted, when you are ventilating, the gas will enter the stomach. So after a lot of gas is present in the stomach, what it will cause is, it will cause aspiration. It will cause the patient to vomit the gastric contents into the trachea. So that will cause chemical pneumonitis. And you, as an anesthetist, trust me, you never want to be in that situation. So because of that fear itself, many anesthetists will not use LMA if they know the patient is not full stomach. And many anesthetists will not use LMA as a toto. So some anesthetists will use when there is definitive indication. And other neurovascular complications. Sometimes hypoglossal nerve is very close to the pharyngeal recess. So when you put too much cuff, like over jealously, when you put too much cuff, that's no gas should escape, what will happen? It will compress the neck structure and it will cause nerve injuries. That is very dangerous, and sometimes even esophageal rupture and perforation. I have never seen this, but these are all complications which has been noted. Now coming on to definition. So there is something called as leak pressure, there is something called as seal pressure. So leak pressure is nothing but the maximum pressure beyond which clinically detectable leak is present on the control ventilation. I am 100% sure nobody would have understood anything. So we will see what it is. See, now when you inserted an LMA and you put the desired volume of cuff. So in this, this is a 4 size LMA, and in this they have given, I am not sure whether you will be able to see. So in this they have given 30 ml can be inserted. So after putting 30 ml of air through this pilot balloon, so what will happen is the pressure inside this cuff will be 60 millimeters of mercury. 60 millimeters of water. So that is the maximum pressure. You cannot go more than that. So with this 60 millimeters of mercury water, your leak pressure will be 20 centimeter of water for airway. I will tell you. So normally when you ventilate when you give positive pressure ventilation, your airway pressure will be shown in the machine. So it should not go more than 20 centimeter of water. If it goes more than 20 centimeter of water, what will happen is air will leak through this cuff, not through this cuff. Air will leak on the surroundings of the larynx. It won't go into the larynx. Air will leak out of the larynx. So that is called as leak pressure. So after putting the LMA in place and putting the cuff, the desired volume of cuff, that is 30 for every LMA there is a different cuff volume. So the correct volume of the cuff should be set. After that, when you are ventilating, if the airway pressure in the ventilator airway pressure goes more than 20, there will be leak. So that is called as leak pressure. For every LMA there is a desired leak pressure. There is a preset leak pressure. Now coming on to sealing pressure. So sealing pressure is nothing but, I told you there is a 60 centimeter of water, no? So this is sealing pressure. So this is the maximum pressure beyond which regurgitation occurs. So if you keep the pressure less than this or more than this, the patient can have regurgitation. That is what they are saying. I don't think these leak pressure and sealing pressure will be asked, but for understanding I told you. Now coming on to classification of LMA. So supraglottic airway devices can be classified into first generation and second generation. First generation, it is very simple. Only the airway tube is there. So this is the first generation LMA. If it is a second generation tube, second generation LMA tube, additionally these things will be there. It is additional designed to reduce aspiration. So there will be a additional port apart from this airway tube. There will be additional tube to reduce the gastric volume or reduce the gastric aspiration. A gastric decompression tube will be there. That belongs to second generation. And higher sealing pressure to enable control ventilation at higher airway pressures. So higher sealing pressures will be there, and controlled what is that, to control ventilation, to produce control ventilator, to put the patient on ventilator. That is what they are saying. And integral bite block will be there. In this, it is flexible. It is a easily you can bend, patient can bite and cut the tube, but in an advanced LMA like in second generation LMA, there will be bite block, so patient cannot bite it. Then based on evolution, the first generation devices, these are all the first generation simple airway tubes. There is LMA classic, then flexible LMA, unique LMA, cobra LMA. So combi tube, all these are first generation because they have only the airway passage. Second generation is with an additional drainage tube for gastric decompression, that is ProSeal LMA, iGel, laryngeal tube, LMA Supreme, Slippa. Third generation. So this slide I put only for you to remember the generation. So we know first generation and second generation, but there are some classification which classify one LMA as a third generation LMA. So this is Baska mask. It is called as Baska mask. So this Baska mask, I think it may come as an MCQ question. So they will ask all the following are second generation LMA except the following is a third generation LMA. You can mask it as Baska mask. You can write it as Baska mask. Now you remember first generation LMA only airway tube, second generation LMA additional gastric desufflation port, high sealing pressure, then the third thing is bite block. Third generation only one, that is Baska mask. Now each LMA we will be discussing in the next lecture. I will definitely make you understand and make you identify all the LMAs very easily.